Thank you. Question to Dr. Iyengar. The common things that we have discussions with our radiation oncologists, like, in the case of oligoprogression, you're considering radiation, the patient, let's say, continues on, osimertinib or lorlatinib. Do we have to stop the drug? Can we radiate while continue targeted therapy? What is there special radiation locations where you want to stop preferentially versus others where I really don't care, you can continue? How do you approach that discussion?
Yeah, that's an amazing question. And despite having done this for so long, we still don't have ideal answers. I mean, so, I it's a much more simple question when you're talking about chemotherapy, for instance, right? I mean, if we're treating the spine, if we're treating the brain, if we're treating any kind of viscera, we want to avoid doing it in combination. I don't have necessarily those concerns with TKIs, with osimertinib or lorlatinib. What I'm more worried about, the synergy of each of the treatments with respect to pulmonary toxicity is, I think, probably my bigger concern. And so I would argue that if we're treating large field in the lungs, whether it's primary with mediastinal adenopathy or so forth, then I may ask them to hold off the EGFR inhibitor for a little bit of time. If it's SBRT to a small lung lesion or some of the other things I mentioned, I'm not really as concerned about. But I don't hold it against people who want to stop the EGFR inhibitor 3 days before and 3 days after radiation for SRS or for SBRT, because we just have limited data. But at least from the trials I've been involved in where we did not hold it, there was not any increased toxicity signal.